Welcome to the deep dive. Today, we are really getting into the weeds, aiming for that professional level understanding of probably the most fundamental mechanical challenge in all of human biology.
That's right. We're talking about the passage of the fetal skull through the maternal pelvis.
And this isn't just, memorizing parts. It's about the geometry, the physics of it all, and how that translates directly into clinical practice, into prediction.
Exactly. We're pulling from some really detailed textbook sources today. We're talking millimeters, angles, bony structures that just, well, they don't yield easily.
So if you're aiming for that true mastery, the structures, the measurements, the implications for obstetrics, this deep dive should get you there.
Yeah, the big picture here, the thing to keep in mind throughout is this interplay. You've got this object, the fetal head, which can actually compress and change shape a bit.
Semi-compressible.
Right. And it has to navigate this relatively fixed, really quite intricate bony framework, the maternal pelvis.
It's a negotiation, isn't it?
Absolutely. Labor is essentially a sophisticated negotiation between these two structures. And knowing the typical measurements, the potential variations, it allows clinicians to do more than just observe.
You can predict potential problems.
You can predict, you can intervene appropriately, you can manage things like cephalopelvic disproportion, that mismatch between head size and pelvis size, hopefully long before it becomes a crisis.
So it's dynamic. We need to see these not as static diagrams, but as structures interacting under, well, immense pressure.
Precisely. Let's dive in.
Okay, let's start with the passenger, the fetal skull. The sources really hammer home this duality in how it's built. There are parts that can give way and parts that absolutely cannot.
Yeah, it's actually a fascinating piece of biological engineering, really optimized for birth. The skull is basically divided into two main zones. You've got the vault,
The top part?
right, the top and sides, formed by these thin, quite pliable, flat bones. Importantly, they're joined by these membranous gaps, the sutures, which makes the whole vault compressible, changeable.
But that's anchored to something solid.
Exactly. This flexible vault sits on the base of the skull, and the base is made of thick, rigid, completely incompressible bones.
So it's strategic. The part that needs to squeeze through the birth canal can change shape, but the really critical structures like the brainstem, the major nerves and vessels down there are protected inside that rigid, unyielding base.
Precisely. If the base could compress, birth would be neurologically catastrophic. The flexibility is put exactly where it needs to be.
Okay. But for an obstetrician, looking at the head during labor, it's divided differently, isn't it? Into regions that tell you how the baby is presenting.
Yes, absolutely. We think in terms of 4 specific regions, and identifying which one is leading tells us immediately about the potential challenges.
Let's define those, starting with the ideal scenario, the best presenting part.
That's the vertex. And it's important to be precise here. It's not just the top of the head. It's a specific sort of quadrangular area.
Okay, what defines its boundaries?
Right, so anteriorly, you've got the bregma, that's the anterior fontanel, the big soft spot, and the coronal sutures running sideways. Posteriorly, it's bounded by the lambda, the posterior fontanel, and the lambdoid sutures.
And the sides.
Laterally, it's marked by imaginary lines running through the parietal eminences. Those are the bony bumps on the side of the head.
And why is this the sweet spot?
Because when the vertex presents perfectly, it means the smallest, most favorable diameters of the head are engaging with the pelvis. It's the path of least resistance.
Okay, but what if the head isn't tucked down perfectly? If it's slightly lifted or deflexed?
Then we move from the vertex into the next zone, which is the brow, sometimes called the sinciput.
Where does that area lie?
The brow basically stretches from the front edge of the vertex, so the anterior fontanel and coronal sutures, down to the top of the face, which is defined by the root of the nose and the supraorbital ridges, the bony bits above the eyes.
And presenting the brow is bad news.
Well, it immediately tells you that a much larger, often completely unsustainable diameter of the head is trying to fit into the pelvis. It signals a potential problem.
And if the head is extended even further back?
Then you get a face presentation. Anatomically, the face is defined as the area between those supraorbital ridges and the root of the nose, down to where the floor of the mouth meets the neck.
Face presentations can sometimes work, though, can't they?
They can, yeah. They require a very specific mechanism of labor, specific rotations, but if the head achieves complete extension, the diameter can actually be quite favorable again, similar to the vertex. But it's a different journey.
And just to cover all bases, the last region.
Is the occiput. And that's defined very strictly. It's just the occipital bone itself, the bone at the very back of the head.
So understanding vertex, brow, face, occiput, these aren't just academic labels. They dictate the entire approach to labor management.
Absolutely. They tell you the likely mechanism, the potential difficulties, and influence decisions about delivery.
Now, you mentioned the source of the vault's flexibility, these sutures. These are basically what, gaps? Membranes?
Exactly. They're non-ossified membranes, essentially connective tissue, that unite those flat bones of the vault.
And there are specific ones we need to know.
There are 4 main groups. Running front to back, right down the midline, separating the 2 parietal bones, is the sagittal suture, sometimes called the longitudinal suture.
Okay.
Then running side to side, separating the parietal bones from the frontal bones at the front, are the 2 coronal sutures.
Got it.
Anteriorly, between the 2 halves of the frontal bone, is the frontal suture. This one usually fuses later in infancy.
Right.
And posteriorly, separating the single occipital bone from the 2 parietal bones, are the lambdoid sutures.
And the big function here is allowing movement.
That's the key mechanical function, yes. They permit this gliding movement, one bone sliding slightly over the adjacent one. That's what we call moulding.
But clinically, feeling these during an exam is crucial, isn't it?
Oh, absolutely non-negotiable.
Yeah.
Especially palpating the sagittal suture during an internal vaginal examination. It gives you immediate, real-time information on 3 critical things.
Like what?
First, the manner of engagement. Is the head coming in straight, which we call synclitism, or is it tilted to one side, asynclitism? The orientation of the sagittal suture tells you that.
Okay, that makes sense. What else?
Second, the degree of internal rotation. Has the head started to turn to fit the pelvis? Where the sagittal suture is pointing relative to the mother's pelvis indicates the progress of rotation.
1/3.
The degree of moulding that's already happening. Can you feel a gap between the bones? Are they just touching or are they overlapping? That tells you how much pressure the head is under.
So the sutures are lines. Where they meet, you get wider gaps, the fontanels or soft spots. 2 are really important landmarks, right?
Yes, 2 major ones for obstetrics. The biggest, most obvious one is the anterior fontanel, also known as the bregma.
That's the one at the front.
Correct. It's where 4 sutures meet. The frontal suture in front, the sagittal suture behind, and the 2 coronal sutures coming in from the sides.
And it's quite large.
Yeah, it's noticeably large, roughly diamond-shaped, measuring about 3 centimeters by 3 centimeters.
That large size must be important for molding.
Definitely. It provides a big area of flexibility. But it stays open for a long time after birth, too, doesn't it? Usually until about 18 months.
Why so long?
That extended period of being open, or patent it should close by 18 months, maybe 24 months, pathologically, is absolutely crucial for accommodating the incredible rapid brain growth that happens in the first year of life.
Ah, okay. And clinically during labor?
During labor, finding that diamond shape tells you immediately about the degree of head flexion. How tucked down is the chin? Postpartum, feeling the tension in that membrane is a classic diagnostic tool.
How so?
If the fontanel feels sunken, depressed, it's a strong sign of dehydration. If it feels tense, bulging, elevated, that's a major warning sign for raised intracranial pressure, or ICP.
Like pressure inside the skull.
Exactly. It's a direct window, almost.
The sources also mention some more specialized uses.
Yeah, though much rarer nowadays with modern imaging and techniques. But historically, and sometimes still in specific situations, that large fontanel provided access. The big vein running underneath, the superior longitudinal sinus, could be accessed for blood samples or even exchange transfusions.
Wow.
And theoretically, you could even access the cerebrospinal fluid, the CSF, from the ventricles deep inside the brain through the angle of the fontanel. But again, very specialized.
Okay, let's move to the back. The smaller triangular one.
That's the posterior fontanel, or lambda.
The lambda, where is that located?
It's formed where 3 sutures meet. The sagittal suture coming from the front and the 2 lambdoid sutures coming from the sides and back.
It's much smaller.
Much smaller, yeah.
Yeah.
Only about 1.2 by 1.2 centimeters.
Yeah.
And crucially, the floor of this one often becomes bony, it ossifies, right around the time the baby reaches full term.
So wait, if it's bony at term, why is it still called a fontanelle, a soft spot?
That's a great point. Technically, it's a bit of a misnomer because it might not be soft anymore.
Right.
But the name sticks because it's still a key junction point where those 3 major sutures converge.
And does that difference being smaller and often bony change its clinical role compared to the bregma?
It does. Because it's smaller and might already be ossified, it contributes less significantly to the overall process of molding. Its main importance is as a landmark.
A landmark for what?
For determining the precise position of the head relative to the maternal pelvis. If you feel that small triangular junction, you know exactly which way the back of the baby's head, the occiput, is pointing. It orients you.
Got it. And there's apparently a sagittal fontanelle, too.
Mentioned for completeness, yes. It's an inconsistent finding, sometimes located along the sagittal suture itself, but it really has no clinical significance in managing labor. We focus on bregma and lambda.
Right.
The anterior and posterior are the key players.
Okay, now for the numbers game, the actual measurements. The physics of fitting the head through the pelvis. And the absolute golden rule here seems to be the head's attitude, how flexed or extended it is, dictates everything.
It dictates precisely which anteroposterior, or AP, diameter of the head tries to enter the pelvic inlet. And this list of diameters, well, mastering this is fundamental to understanding the mechanics of labor.
There are 6 main AP measurements.
6 key ones, yes. And the difference between the smallest, most favorable one and the largest, most problematic one is dramatic.
Let's start with the best case scenario, the smallest diameter.
That occurs in complete flexion. The baby's chin is tucked right down onto its chest. In this position, the head presents the suboccipitobregmatic diameter.
Suboccipitobregmatic, and how long is that?
It measures 9.5 centimeters. This is the diameter associated with that ideal vertex presentation we talked about. Notice it's 9.5 centimeters, perfectly matching the typical biparietal diameter, the main width.
Okay, 9.5 centimeters in full flexion. What if the chin isn't quite so tucked? Incomplete flexion.
If the head is slightly less flexed, it pivots just a bit. Presents the suboccipitofrontal diameter. This one is 10 centimeters.
Still vertex.
Still technically a vertex presentation, yes. And 10 centimeters is usually manageable, but it's already half a centimeter longer than the ideal.
Okay. Now, what if the head lifts up more significantly? Marked deflection.
Now we're talking about the occipitofrontal diameter presenting, and this measures 11.5 centimeters.
So we've gone from 9.5 to 10 to 11.5 centimeters. That's a big jump.
It is. You're significantly increasing the bulk of the head that's trying to fit through that fixed pelvic inlet. Engagement becomes much harder.
And this leads us to the really dangerous one, the brow presentation.
Right. If the head is in partial extension, meaning the brow is the leading part, the diameter attempting to engage is the longest one possible, the mentovertical diameter.
Mentovertical. And the measurement.
A massive 14 centimeters.
14, compared to 9.5 centimeters.
Exactly. That jump from 9.5 centimeter to 14 centimeter is, mechanically speaking, often devastating. A 13 centimeter diameter simply will not fit through a normal pelvis. It almost guarantees obstructed labor unless something changes. This single measurement underscores why maintaining good head flexion is so critical.
Wow, okay. But if the head extends even further back into a face presentation, the numbers actually come down again, right?
They do, but the mechanics are different. In incomplete extension, where the face is presenting but not fully extended, the diameter is the submentovertical. That measures 11.5 centimeters.
Same as marked deflection.
Same length, yes, 11.5 centimeters. But now the presenting part is the chin face area, mentum, not the occiput forehead region.
And finally, the best case scenario for a face presentation, complete extension.
Here, the head is extended all the way back. This presents the submentobregmatic diameter. And remarkably, this measures 9.5 centimeters again.
Back to 9.5 centimeters.
Yes. It's this fascinating paradox. The maximum possible flexion, suboccipitobregmatic, and the maximum possible extension, submentobregmatic, both present the smallest, most favorable diameter of 9.5 centimeters.
Allowing passage, but requiring totally different rotational maneuvers.
Totally different mechanisms of labor, yes. Attitude is everything for the AP diameter.
Okay, so that covers the front-to-back measurements, which change with flexion. What about the side-to-side, the transverse diameters? These are always relevant, aren't they?
Yes, the head's width has to clear the pelvis regardless of flexion. The most important transverse measurement, the one we always track, is the biparietal diameter.
Biparietal. Between what points?
It's measured between the widest points of the two parietal bones, those parietal eminences we mentioned earlier. It measures 9.5 centimeters.
And why is it so crucial?
Because no matter the presentation vertex, brow, face, or the position, this 9.5 centimeter biparietal diameter almost always has to engage and pass through the inlet. It's the widest fixed part of the vault.
Are there other transverse measurements we should know?
Yes, a couple more. There's the suprasubparietal diameter, which is 8.5 centimeters. This comes into play if the head engages asynclitically, tilted sideways. It's measured from just below one parietal eminence to just above the opposite one.
Okay.
Then there's the bitemporal diameter, measuring 8 centimeters. That's between the antero-inferior ends of the coronal sutures, basically across the temples.
And you mentioned one measurement earlier that's part of the rigid base, the one that absolutely doesn't change.
That's the bimastoid diameter. It measures 7.5 centimeters, taken between the tips of the mastoid processes, those bony lumps behind the ears. This reflects the width of the skull base.
And it's incompressible.
Absolutely incompressible. No amount of labor force can reduce that 7.5 centimeters width. It's a fixed structural limit.
So if we think about these diameters in terms of the circumference they create, that really highlights the challenge, doesn't it?
It really does. Look at the comparison. That ideal 9.5 centimeter subaccipitobregmatic diameter corresponds to a circumference of roughly 27.5 centimeters.
Okay.
The ideal face presentation, the 9.5 centimeter submentobregmatic, also gives a circumference of 27.5 centimeters.
Makes sense, same diameter.
But now consider the brow presentation with that huge 14 centimeter mentavertical diameter. The circumference required to accommodate that is about 37.5 centimeters.
Wow, a full 10 centimeters larger circumference.
Exactly. That 10 centimeter difference in the required hoop size is the physical reality of why a brow presentation so often leads to obstructed labor. The numbers tell the story.
All right, so the head often has to fit through a space that's only just barely larger than its smallest possible diameter. Some alteration seems inevitable. This is where molding comes in.
Right. Moulding is defined as the alteration of the skull shape while it's passing through that resistant birth passage, the bony pelvis, and the soft tissues.
And it's not really about shrinking the head volume, is it?
That's a key point and often misunderstood. The brain itself is essentially incompressible. What happens during molding is primarily a change in shape, not a significant reduction in volume. The sources mention a tiny bit of cerebrospinal fluid and venous blood might get squeezed out, but it's minimal.
So how does the shape change work?
It's a direct consequence of pressure. The diameter that's engaging the pelvis gets compressed, and this causes a corresponding elongation in the diameter that's at a right angle to it.
Like squeezing a balloon.
Sort of, yeah. If the subaccipitobregmatic diameter, front to back inflection, is being squeezed, the mentavertical diameter, top to bottom, will tend to elongate slightly. In a normal, uncomplicated delivery, the overall change in diameter due to molding is usually quite small, around 4 millimeters or so.
And mechanically, it involves those flat bones actually shifting relative to each other at the suture.
Exactly. It's like miniature tectonic plates. The pliable parietal bones are the main players. They tend to slide over the adjacent bone.
Overlapping.
Yes. The parietal bones often overlap the occipital bone behind them, the frontal bones in front of them, and the temporal bones at the sides.
And you can even tell the baby's position from how they overlap. That seems subtle.
It is subtle, but observable. For instance, in the most common position, the first vertex position where the baby's occiput is pointing towards the mother's left and slightly forward, it's typically the right parietal bone that overrides the left one.
And the opposite for the second position.
Correct. In the second vertex position, occiput to the right, the left parietal tends to override the right. This overlapping usually resolves within a few hours after birth as the pressure is relieved, but seeing it during labor gives you diagnostic clues.
Clinically, how is molding assessed or graded?
We use a simple grading system, usually grades 1, 2, and 3.
Okay, what do they mean?
Grade 1 molding means the edges of the cranial bones are touching at the suture line, but they aren't overlapping.
Grade 2.
Grade 2 means the bones are overlapping, but you can still separate them with gentle pressure from your examining finger. They're not jammed together.
And grade 3.
Grade 3 is the most significant. It indicates fixed overlapping. The bones are overlapping, and you cannot separate them with finger pressure. They are rigidly overriding each other.
And the significance, grade 1 or 2 is okay?
Slight molding, like grade 1 and often grade 2, is actually beneficial. It's the head adapting to the passage, enabling delivery. But grade 3 molding, especially if it occurs early in labor or high up in the pelvis, is a serious warning sign. It strongly suggests there's a significant mismatch, probably cephalopelvic disproportion. And severe fixed molding carries a real risk of serious intracranial injury. Things like tearing the membranes within the skull, like the tentorium cerebellis, or causing bleeding, like a subdural hemorrhage.
Okay, so molding is the bone shape changing. What about the swelling you sometimes see on the baby's scalp? The caput succedaneum.
Right, caput is different. It's not bone-changing shape, it's soft tissue swelling. Specifically, it's a collection of fluid edema in the layers of the scalp.
What causes it?
It's caused by pressure and fluid stagnation. As the head presses against the cervix or the bony pelvis, there's a ring of contact, often called the girdle of contact. Inside this ring, scalp tissue is compressed. Outside the ring, in the leading part of the scalp that's not directly pressed against anything, the pressure interferes with venous return and lymphatic drainage.
So fluid builds up in the unsupported area.
Exactly. Fluid stagnates in the scalp layers beneath that girdle of contact. This usually happens after the membranes have ruptured, when the head is directly applied to the cervix or pelvis.
How does a clinician tell kaput apart from something more serious, like bleeding under the bone membrane, a cephalometoma?
There's one absolutely key distinguishing feature: suture lines. Caput succedaneum is a diffuse, boggy swelling, and crucially, it is not limited by suture lines. It feels soft and can cross right over the sagittal or coronal sutures.
And a cephalometoma.
Cephalometoma is bleeding underneath the periosteum, the membrane covering a specific bone. Because of this, it is always strictly limited by the suture lines of that single bone. It won't cross over to the adjacent bone. Also, caput is present at birth and disappears quickly, usually within 24 hours, while a cephalometoma might appear later and take weeks to resolve.
So kaput is generally benign.
Yes, it looks dramatic sometimes, but it's benign and resolves on its own.
But does it tell us anything useful during labor?
It does, actually. First, the presence of caput signifies that the head has been stationary, pressing against that girdle of contact for some time. It suggests labor might be slowing down or meeting resistance at that point.
And the location of the swelling.
The location gives you clues about the baby's position and flexion. For example, if the caput forms primarily on the baby's right parietal bone, it suggests the baby is likely in a left position, like left occiput anterior or transverse.
Why?
Because in a left position, the right parietal bone is the leading part pressing against the cervix. Similarly, if the caput is very far back towards the occiput, it suggests the head is well flexed. If it's more towards the front, it suggests less flexion. It's another piece of the puzzle.
All right, we've covered the passenger, the fetal skull, with its amazing ability to mold and adapt. But all that adapting is forced by the journey it has to take through the relatively unyielding structure of the maternal pelvis. Let's shift focus to the canal itself.
Right, the bony pelvis. It's a strong ring structure, basically composed of 4 bones. You have the 2 large innominate bones on the sides and front.
Those are the hip bones.
Yeah, each innominate bone is actually formed from the fusion of 3 parts, the ilium, ischium, and pubis. Then posteriorly, you have the sacrum, that triangular bone at the base of the spine, and below that, the little coccyx, or tailbone.
And these are held together by joints.
4 main joints lengthen them. The 2 sacroiliac joints, where the sacrum connects to the iliac parts of the innominate bones, the sacrocythageal joint between the sacrum and coccyx, and the symphysis pubis joining the 2 pubic bones at the front.
Functionally, we divide the pelvis into 2 parts, right? The false and the true pelvis.
We do. The false pelvis is the upper flared-out part. It's formed mainly by the iliac bones.
Boundaries.
Posteriorly, it's bounded by the lumbar vertebrae. Laterally, by the wide, shallow depressions called the iliac fossae, and anteriorly by the lower part of the anterior abdominal wall.
And its role in obstetrics.
Primarily, it supports the enlarging uterus during pregnancy. It doesn't really form part of the birth canal itself. However, obstetricians often look at its general size and shape, because large external dimensions of the false pelvis can sometimes suggest a roomy true pelvis below, though it's not a guarantee.
The real action happens in the true pelvis.
Exactly. The true pelvis is the actual bony canal the baby must pass through. It's below the false pelvis. An interesting feature is its asymmetry in depth.
How so?
It's quite shallow at the front. The symphysis pubis is only about 4 centimeters high, but it's much deeper at the back, following the curve of the sacrum and coccyx, measuring about 11.5 centimeters posteriorly.
And this true pelvis is further divided.
Conventionally, yes. We think of it as having an inlet, the top opening, a cavity, the middle section, and an outlet, the bottom opening.
The dividing line between the false pelvis above and the true pelvis below is called the pelvic brim, or inlet. It's a very specific bony ring, isn't it?
Extremely specific. You need to be able to mentally trace the landmarks that form this brim. There are 9 key points.
Let's list them, starting at the front and going around one side.
Okay, starting right at the front midline. 1, the upper border of the symphysis pubis, moving laterally. 2, the pubic crest. 3, the pubic tubercle, a little bony knob, then continuing along the bone. 4, the pectineal line. 5, the iliopubic eminence, a slight bulge where ilium and pubis meet. Then 6, the iliopectineal line, which is really a continuation, reaching the back. 7, the sacroiliac articulation, the joint, then curving medially along the sacrum. 8, the anterior border of the ella, or wing, of the sacrum. And finally, 9, the midpoint of the sacral promontory.
The sacral promontory, that's the top forwardmost edge of the sacrum.
Exactly. That defined, rigid, bony ring formed by these 9 landmarks is the gateway. Everything depends on the fetus being able to enter the true pelvis through that brim. Hashtag 2.2, the inlet. Superior straight, angulation, and dimensions.
Okay, the inlet, also called the superior straight or pelvic brim. Ideally, its shape is favorable, typically described as almost round in the classic female gynecoid pelvis. But its angle, how it sits in the body, is really important too.
Critically important. The plane of the inlet isn't horizontal when a woman is standing upright. It's tilted. It makes an angle of about 55 degrees with the horizontal plane. We call this the angle of inclination.
55 degrees? That seems quite steep.
It is. Radiographically, looking at X-rays, the angle between the plane of the inlet and the front surface of the fifth lumbar vertebra above it is normally around 135 degrees. This tilt has major implications for how the baby engages.
What happens if that angle is off? Say, if the inclination is too high.
A high inclination, meaning an angle significantly greater than 55 degrees, may be due to anatomical variations like the fifth lumbar vertebra being fused to the sacrum, sacralization, can really complicate labor.
How so?
Because the main force of uterine contractions pushes downwards along the uterine axis. If the inlet is tilted too steeply, that force doesn't align well with the axis of the inlet itself. It makes it harder for the head to actually enter the pelvis.
So delayed engagement.
Delayed engagement is common. A high inclination also tends to favor the baby settling into less ideal positions, particularly the occipito-posterior position, where the back of the baby's head is towards the mother's back. And it can make the subsequent descent and internal rotation more difficult too.
Okay. What about the opposite? A low inclination, less than 55 degrees. Maybe if the first piece of the sacrum acts more like a lumbar vertebra, lumbarization.
That's generally not a problem obstetricially. A lower inclination actually tends to align the uterine axis better with the inlet axis, which can facilitate earlier and easier engagement. So typically no adverse significance there.
Another angle mentioned is the sacral angle. What's that?
That's the angle formed between the line of the true conjugate, we'll define that in a moment, and the anterior surface of the first two pieces of the sacrum. Normally, this angle should be more than 90 degrees.
And if it's less?
A smaller angle, less than 90 degrees, suggests that the sacrum curves forward too sharply, potentially causing the pelvis to narrow or funnel from top to bottom, which isn't ideal.
We also need to think about the axis of the inlet, the direction the baby needs to travel.
Right. The axis of the inlet is an imaginary line drawn perpendicular to the center of the inlet plane. It points downwards and backwards, following that 55-degree inclination.
And the uterine contractions need to push along this line.
Ideally, yes. For contractions to be most effective at pushing the baby into the pelvis, the axis of the uterus needs to coincide with this axis of the inlet. If the uterus is tilted too far forward or back, the force isn't applied efficiently.
Okay, let's get to the absolute make-or-break measurements of the inlet. The anteroposterior diameters, the conjugates, there are 3 of them.
3 key AP measurements, yes. They define the front-to-back space. First, there's the true conjugate, also called the anatomical conjugate or conjugate vera.
Where does that run?
It's measured from the midpoint of the sacral promontory at the back to the inner margin of the upper border of the symphysis pubis at the front. It typically measures about 11 centimeters.
Can you measure that clinically?
No. Because of the bladder sitting in front of the uterus and the angle, you can't directly feel or measure this upper point of the symphysis pubis from inside during a vaginal exam. It's an anatomical measurement.
Okay, so what's the most important one, functionally?
That would be the obstetric conjugate. This is the shortest AP diameter of the inlet and therefore the most critical dimension the head has to clear.
Where does it run and how long is it?
It also runs from the sacral promontory at the back, but it goes to the most prominent bony point on the inner surface of the symphysis pubis, which is usually slightly lower down than the upper margin. This obstetric conjugate measures about 10 centimeters typically.
10 centimeters? That sounds tight for a 9.5 centimeter head diameter.
It is tight. That 10 centimeter space is the absolute gatekeeper. It dictates whether the average fetal head's biparietal diameter, 9.5 centimeters, can physically pass through the inlet. But like the true conjugate, you also cannot measure this one directly during a clinical exam.
Which leads us to the third one, the one we can measure.
Exactly. That's the diagonal conjugate. This one is measurable clinically. It measures about 12 centimeters.
Yeah, it's landmarks.
It runs from the lower border of the symphysis pubis, which you can feel, diagonally upwards and backwards, to the midpoint of the sacral promontory, which you try to reach.
So this 12 centimeter diagonal conjugate is our clinical proxy for the crucial 10 centimeter obstetric conjugate.
Precisely. We measure the diagonal conjugate and then estimate the obstetric conjugate from it.
Okay, the sources go into detail on how to measure the diagonal conjugate clinically. Can we walk through that technique? It sounds vital.
Absolutely vital skill. It requires care and aseptic technique. The patient is usually in the dorsal position, lying on her back. The examiner inserts two fingers, usually the index and middle fingers, into the vagina.
Aiming for the back.
Yes, aiming upwards and backwards, following the curve of the sacrum. The goal is to reach the sacral promontory with the tip of the middle finger.
Is it easy to reach?
In a pelvis with adequate dimensions, it should actually be quite difficult, or even impossible, to easily touch the promontory. If you can reach it easily, it might suggest the AP diameter is short.
What if he can't quite reach it?
You might need to maneuver. The examiner often has to depress their wrist and elbow downwards towards the perineum quite significantly. This helps align the fingers with that steep upward angle of the pelvic inlet to maximize reach. You feel for where the smooth curve of the sacrum ends and the bony ridge of the promontory begins.
Okay, let's say you've reached the promontory with your middle fingertip. What's the next step?
While keeping the middle finger firmly on the promontory, you carefully raise your hand upwards until the side of your index finger, or the part of your hand just below the index finger, presses firmly against the underside of the symphysis pubis, right under the pubic arch.
Marking the spot.
Exactly. You mark that point on your gloved finger, the point that was directly under the symphysis. Then you withdraw your hand carefully.
And measure.
You measure the distance from the tip of your middle finger, which was on the promontory, to the mark you made on your index finger, which was under the symphysis. That measured distance is the diagonal conjugate.
And the final step, getting the obstetric conjugate.
This is the crucial inference. You subtract a certain amount from the measured diagonal conjugate to estimate the obstetric conjugate. Typically, you subtract between 1.5 and 2 centimeters.
Why the range?
It depends on the height and the angle of the symphysis pubis itself, which varies between women. A taller, more angled symphysis requires a larger subtraction.
So if the diagonal conjugate measures 12 centimeters, the obstetric conjugate is likely around 10 to 10.5 centimeters.
Exactly. And the clinical rule of thumb remains. If you can barely reach the promontory, or can't reach it at all, the AP diameter of the inlet is very likely adequate for an average-sized baby.
Okay, that covers the critical AP diameters. What about the width of the inlet, the transverse diameter?
Yeah. The widest anatomical transverse diameter of the inlet is measured across the pelvic brim between the farthest points on the iliopectineal lines on either side. This typically measures about 13 centimeters.
But the head doesn't always use the absolute widest part.
Not always. The actual space available, the available or obstetrical transverse diameter, might be slightly less than that anatomical maximum, depending on the exact shape. We also measure the oblique diameters.
Oblique, running diagonally.
Yes, there's a right oblique and a left oblique. They run from one sacroiliac joint at the back to the opposite iliopubic eminence at the front. Each oblique diameter measures about 12 centimeters. Often the head engages in one of these oblique diameters.
And there was one more specific 9.5 centimeter diameter mentioned.
Yes, the sacrocotyloid diameter. This is measured from the midpoint of the sacral promontory to the iliopubic eminence on the same side.
Why is that 9.5 centimeters significant?
Because it represents the space available for the fetal head's 9.5 centimeter biparietal diameter to pass, especially if the pelvis is flattened front to back, a platypeloid pelvis. If this sacrocotyloid space is less than 9.5 centimeters, the biparietal diameter simply won't fit through that part of the inlet. It's a measure of posterior pelvic capacity. Hashtag 2.3 the cavity, and mid-pelvis, the rhomiest and the narrowest planes.
Okay, once the head successfully negotiates the inlet, it enters the pelvic cavity. This is the space between the inlet above and the narrowest part of the pelvis below.
Right. And within this cavity, there's actually a region where things open up quite a bit. It's called the plane of greatest pelvic dimensions.
The roomiest part.
Exactly. This plane is generally considered the most spacious part of the entire true pelvis. It's almost round in shape.
Where is it located?
It extends roughly from the midpoint of the posterior inner surface of the symphysis pubis at the front, back to the junction between the second and third sacral vertebrae, S2 and S3.
And the measurements reflect this roominess.
They do. Both the anteroposterior diameter and the transverse diameter in this plane measure about 12 centimeters each. The axis of the pelvis here is directed almost straight downwards. It's kind of a holding area where the head can maneuver before hitting the next constriction.
So below the spacious plane, we enter the mid-pelvis. This area leads down to the narrowest point, right?
Correct. The mid-pelvis is bounded below by what we call the mid-pelvic plane, or sometimes the plane of least pelvic dimensions, though that term is often used more specifically for the absolute narrowest point. This mid-pelvic plane is defined as extending from the lower border of the symphysis pubis, passing through the level of the ischial spines.
The ischial spines, those are bony points we can feel.
Yes, they are prominent bony projections pointing inwards from the ischial part of the innominate bones. They are crucial landmarks.
And the measurements start to tighten up here in the mid-pelvis.
They do. The key transverse measurement here is the bispinous diameter, the distance directly between the tips of the two ischial spines. This typically measures 10.5 centimeters.
Narrower than the inlet's transverse diameter.
Significantly narrower, yes. Down from 13 centimeters at the inlet transverse to 10.5 centimeters between the spines. The AP diameter in this midplane is about 11.5 centimeters, and the posterior sagittal diameter from the midpoint of the spines back to the sacrum is about 4.5 centimeters. This is where the pelvis really starts to funnel. Hashtag, TAG 2.4, the outlet final measurements and clinical checks.
Which brings us down towards the exit. The sources make a distinction between the obstetrical outlet and the anatomical outlet. Let's start with the narrowest point overall, the plane of least pelvic dimensions, sometimes called the narrow pelvic plane. This seems to define the upper limit of the functional outlet.
It really does. And this plane is arguably the most clinically significant plane during the descent phase of labor.
Where exactly does it run?
It extends from the lower border of the symphysis pubis at the front, passes directly through the tips of those critical ischial spines laterally, and ends at the tip of the fifth sacral vertebra, S5, posteriorly.
And why is it considered so incredibly important? The sources highlight several reasons in box 9.1.
Okay, let's break those down. First, as the name implies, it is mathematically the narrowest plane in the entire bony pelvis. Every key diameter passing through this level is smaller than the corresponding diameter at the inlet or in the roomiest part of the cavity.
So it's the ultimate bottleneck.
It's the critical bottleneck, yes. Second, this is the level where internal rotation of the fetal head must occur. The head usually enters the pelvis in a transverse or oblique diameter, but to exit, it needs to rotate to an anteroposterior position, usually occiput anterior. This rotation happens as the head negotiates this narrow bispinous diameter.
Okay, what else?
Third, this plane marks the point where the pelvic axis begins its sharp forward curve. The path of the baby changes direction here.
And clinically, those ischial spines themselves are used as direct landmarks?
Two major clinical uses.
Yeah.
First, the ischial spines are the key landmark for performing a pudendal nerve block, injecting local anesthetic to numb the perineum for delivery or repairs. The nerve runs right behind the spine.
And the second use?
Perhaps the most universally known. The ischial spines define station 0-pan in describing fetal descent. When the lowest bony part of the presenting fetal part, usually the head, is level with the plane of the ischial spines, the station is 0. Above the spines is negative station, -1, I like to do -3 centimeters. Below is positive station, +1, +2, +3 centimeters. Reaching station 0 signifies that the largest diameter of the head, the biparietal, has successfully passed through the pelvic inlet. The head is officially engaged.
And the key diameter at this narrowest plane is still that bispinous diameter.
Yes, the transverse or bispinous diameter here is 10.5 centimeters. The AP diameter from lower symphysis to S5 tip is about 11 centimeters, and the posterior sagittal diameter, midpoint of spines to S5 tip, is about 5 centimeters.
Okay, so that's the narrowest functional plane. Below that, we have the anatomical outlet or bony outlet. This is the actual hole at the bottom of the pelvis. What shape is it?
It's typically described as diamond-shaped. It's actually composed of two triangles sharing a common base.
What forms the boundaries of this diamond?
Anteriorly, the lower border of the symphysis pubis. Anterolaterally, the ischiopubic rami, the bones you feel when sitting. Laterally, at the widest points, the ischiotuberosities, the sit bones. Posterolaterally, the strong sacrotuberous ligaments, and posteriorly, the tip of the coccyx.
And the diameters here, there's a variable one, isn't there?
Yes, the critical anteroposterior AP diameter is variable. It's measured from the lower border of the symphysis pubis to the tip of the coccyx. It can measure up to 13 centimeters.
But only if.
Only if the coccyx gets pushed backwards out of the way by the descending fetal head during the second stage of labor. If the sacrococcygeal joint is fused or stiff and the coccyx doesn't move back, the effective AP diameter is significantly reduced, maybe by 2.5 centimeters or so.
Wow, that's a big difference. What about the transverse width of the outlet?
The key transverse measurement here is the intertuberous diameter, also called the biischial diameter. It's the distance between the inner borders of the two ischial tuberosities. This should normally measure about 11 centimeters.
And the posterior sagittal diameter of the outlet?
That's measured from the midpoint of the intertuberous diameter back to the tip of the potentially mobile cos apex. It's about 8.5 centimeters. The space behind the ischial tuberosities is important if the front part of the outlet is narrow.
Which brings us to the architecture at the front, the pubic arch.
Exactly. The angle formed just below the symphysis pubis by the two descending pubic rami is the subpubic angle. In a typical female gynecoid pelvis, this angle should be wide, around 85 degrees or more.
And we assess the pubic arch itself.
Yes, clinically. You assess the space under the arch. A common way is to see if you can place 3 fingers side by side transversely, about 2 centimeters below the apex of the arch. This distance should normally be around 6 centimeters.
What happens if this angle is narrow, less than 85 degrees, and the arch is tight?
A narrow subpubic angle and tight arch are characteristic of an android, male-like, or anthropoid pelvis. This forces the fetal head to be displaced backwards as it tries to exit. This backward displacement creates what's called the waist space of Morris.
The waist space of Morris, that sounds technically important. Explain that.
It is. Imagine trying to fit a circle, the fetal head, under that pubic arch. If the arch is wide, the circle fits snugly underneath. If the arch is narrow and pointed, the top of the circle hits the sides of the arch too early, leaving a wasted gap between the very front of the symphysis and where the head can actually sit.
So it's unused space at the very front.
Exactly. It's measured as the distance between the symphysis pubis and the circumference of an imaginary 9.3 centimeter disc, approximating the diameter of a well-flexed head, when that disc is placed as far forward as possible under the arch.
And how much waist space is acceptable?
Ideally, in a good gynecoid pelvis, this waist space should not exceed 1 centimeter.
What if it's more than 1 centimeter because the arch is narrow?
If the waist space is significant, more than 1 centimeter, it means the head cannot use the full anatomical AP diameter of the outlet. The head is effectively being pushed back. In this situation, the clinician needs to consider the available anteroposterior diameter of escape.
How is that calculated?
It's measured from the tip of the sacrum, not to the symphysis, but to a point further back on the pubic rami that corresponds to the edge of that wasted space. You're measuring the functional AP diameter that the head can actually use, which will be less than the anatomical measurement. Failing to account for significant waist space can lead to unexpected difficulty at the outlet. Hashtag tag 2.5 pelvic axis joints and physiological changes.
So we've mapped the bony structure. Let's wrap up by considering the actual path the baby takes the pelvic axis and the fact that the fixed pelvis isn't entirely fixed during labor.
Right. There are 2 concepts of the pelvic axis. First is the purely anatomical axis, sometimes called the curve of Carus.
What's that?
It's an imaginary line that joins the center points of the plane of the inlet, the cavity, and the outlet. It follows the smooth, concave curve of the sacrum. It looks neat on diagrams, but the fetus does not actually follow this uniform curve.
So what path does it follow?
It follows the obstetrical axis. This is the functional path dictated by the pelvic shape and the pelvic floor muscles.
Describe that path.
Initially, as the head descends from the inlet, the path is directed downwards and backwards, following the general slope of the upper sacrum and the inlet inclination. This direction continues until the head reaches the level of the ischial spines, our station 0 landmark.
And then it changes.
Dramatically.
Yeah.
At the level of the ischial spines, influenced by the funnel shape and the muscular pelvic floor, the axis abruptly turns forwards toward the outlet and under the pubic arch. It's often described as a J-shaped curve rather than a smooth C shape. Understanding this sudden forward redirection is key to understanding the final stages of descent and expulsion.
Finally, you mentioned the pelvis isn't totally rigid. The joints allow some give.
Yes, this is crucial physiological adaptation. The symphysis pubis at the front is a secondary fibrocartilaginous joint. It has cartilage, but no synovial cavity like, say, the knee. During pregnancy, hormones, particularly progesterone and relaxin, cause softening and relaxation of the ligaments supporting this joint.
Allowing movement.
Yes, it allows some slight gliding movement and separation between the pubic bones. This separation can increase the transverse diameter slightly, perhaps by 5 to 10 millimeters, which might not sound like much, but can be critical.
What about the joints at the back?
The sacroiliac articulations are synovial joints, and they also experience ligamentous relaxation under hormonal influence, allowing a small degree of rotation or nutation. This movement can slightly increase the AP diameter of the inlet during labor.
And the little tailbone.
The sacrococcygeal joint connecting the sacrum and coccygis is typically a synovial hinge joint. This is very important.
Because it allows the coccygis to move backwards.
Exactly. As the fetal head descends onto the pelvic floor and pushes towards the outlet, it normally forces the coccyx to hinge backwards. This movement directly increases the anteroposterior diameter of the anatomical outlet.
By how much?
By that crucial 1.5 to 2.5 centimeters we mentioned earlier. This backward movement of the coccygis provides vital extra space right at the final exit point.
So even things like positioning the mother can leverage this flexibility.
Absolutely. For example, placing a woman in the dorsal lithotomy position, legs up in stirrups, tends to flatten the lumbar curve and can rotate the pelvis slightly, which passively increases the AP diameter of the outlet by maybe 1.5 to 2 centimeters, in addition to allowing the coccygis to move freely backwards. The fixed pelvis has these important dynamic capabilities during labor.
Okay, we have covered an immense amount of ground there, a really deep dive into incredibly precise, interconnected anatomical data. We've aimed for mastery from understanding that 3 by 3 centimeter diamond-shaped bregma.
To tracing the 6 key AP diameters of the fetal skull, knowing the difference between the ideal 9.5 centimeter suboccipital bregmatic and that devastating 14 centimeter mento-vertical diameter. We detailed molding, its grades, and the significance of kaput.
And then we tackled the maternal pelvis. We mentally walked the 9 landmarks of the brim, grasped the absolute necessity of inferring that critical 10 centimeter obstetric conjugate from the clinically measured 12 centimeter diagonal conjugate.
And pinpointed the profound importance of the plane of least pelvic dimensions, the narrowest point defined by that 10.5 centimeter bispinous diameter between the ischial spines, the site of internal rotation, and station 0.
I think the key takeaway for achieving that professional insight is seeing how it all fits together.
Yeah.
It's not just memorizing numbers, it's understanding this constant dynamic negotiation.
Exactly. It's the fetal head's capacity for molding, for overlapping its bones, measured against the pelvis's fixed clearances, like needing less than 1 centimeter of waist space of Morris under the pubic arch, and then factoring in how hormonal relaxation and joint mobility provide those last crucial millimeters of flexibility.
It's the interplay between the fixed measurements and these dynamic processes.
That's what distinguishes true understanding in this field. It's visualizing that negotiation between specific fetal diameters attempting to pass through specific pelvic planes.
Which leads us to a final thought. We talked about how the maternal pelvis isn't entirely fixed, how hormones like relaxin induce physiological loosening, adding maybe a centimeter or so of give to the joints.
Right, that crucial bit of flexibility.
So the provocative question is, given the well-known challenges and risks of cephalopelvic disproportion throughout human history, why hasn't evolution pushed that mechanism further? Why hasn't human anatomy evolved to maximize that physiological enlargement even more significantly?
That's a fascinating point. It speaks to the evolutionary trade-offs, doesn't it? The pelvis needs to be rigid enough for stable, upright walking and supporting the abdominal organs, yet just flexible enough, sometimes barely enough, for childbirth. That dynamic balance between structural integrity and reproductive necessity, mediated by hormones, remains a really compelling area to think about.